This is Elizabeth Auchincloss, and this is episode 9 of the Psychoanalytic Model of the Mind. In this episode, we will talk about the fourth and last model of the mind, self-psychology. Like the topographic model of the mind, and like the early structural model of the mind, self-psychology was largely the work of one man, Heinz Kohut, who developed this model in the 1970s and 80s. Also, like others who developed object relations theory, Kohut was initially schooled in the structural model of the mind, or in ego psychology, but he felt that this model was insufficient to describe or treat the problems that his patients were struggling with. Self-psychology is a theory of the mind based on a core structure of the personality called the self. In this theory, the self is a largely unconscious structure. The self is defined as the center of initiative and a source of the coherent experience of sameness. It is made up of an individual's ambitions, ideals, and talents. In other words, we can see differences and similarities between self-psychology and our other three models in structure and motivation right away. Developmental theory is very important in self-psychology, which describes the growth of the self in great detail. To remind you, development is the fourth parameter along which we need to look at every model of the mind. Self-psychology asserts that the individual is born with an innate set of narcissistic strivings which serve as the major force for motivation in the personality. Narcissism is defined as an investment in the self. These innate narcissistic strivings include needs for aliveness, authenticity, coherence, mastery, safety, autonomy, uniqueness, creativity, sense of agency and purpose, and self-esteem. The self develops from an admixture of innate factors and interactions with caregivers. Among the inborn needs of the infant is a need for recognition from caregivers, who must respond with empathy to an infant's growing self. Empathy is defined as the capacity to feel or to understand the subjective experience of another person. Empathic responsiveness in caregivers, usually the mother or the father, is vital to the development of the self. These empathic caregivers are the child's first self-objects. A self-object is defined as another person who is experienced as part of the self and who fulfills the needs of the self. Indeed, in self-psychology, the self cannot be conceptualized outside of the self-object matrix. According to self-psychology, there are two major narcissistic lines of development, or components of the self, which develop in the child in interaction with caregivers. One component is called the grandiose self, which expresses innate strivings for power and recognition. The grandiose self develops in interaction with a mirroring self-object, who validates and takes pleasure in the child's exhibitionism and accomplishments. The other component of the self is called the idealized parental imago, which results from the child's attribution of omnipotence and perfection to caregivers. The idealized parental imago develops in interaction with an idealized self-object, who provides the strength and calm needed for the child to feel safe and to develop affect regulation. In the course of development, both of these components of the self grow stronger through the gradual internalization of empathic self-object experiences. In other words, internalization occurs in the context of the caregiver's empathic responsiveness to the child's self-object strivings. Over time, the grandiose self matures into stable self-esteem, assertion, and realistic ambition. The idealized parental imago matures into enduring ideals. The mature and healthy self, then, is able to pursue ideals with assertion and energy. Now let's talk about psychopathology and treatment. Self-psychology contributes a great deal to our understanding of both. When an individual has psychopathology, or a disorder of the self feels weak, incoherent, ineffective, and bad, or cannot find meaning in goals or ideals. The self is healthy if it is characterized by feelings of cohesion and continuity, feelings of energy and initiative, mature self-assertion, self-esteem, and pride, and an investment in a stable set of ideals and goals. The self is considered healthy also if it is characterized by the ability to regulate affects and to make use of interactions with self-objects. Disorders of the self result when a caregiver, who is experienced by the child as a self-object, does not mirror the child's grandiosity or reflect back to the child the needed recognition, validation, and joyful acceptance of the child's grandiosity. Disorders of the self also result when a caregiver does not help the child to modulate his grandiosity. In such cases, the grandiose self is either repressed or disavowed, or is poorly integrated within the adult personality. It retains its childish quality and fails to mature into healthy self-esteem and assertion. In serious cases or under severe stress, individuals with disorders of the self may have trouble managing aspects of reality, as in borderline conditions or in addictions. Disorders of the self also result when a caregiver does not allow the child to develop or to modulate the idealized parental imago. Failures such as this occur when the caregiver either seriously disappoints the child or fails consistently to meet expectations. In such cases, wishes for an idealized parent persist in their childish form, or the child may give up on such wishes. In either case, the child is not able to develop lasting ideals and goals. In other words, in disorders of the self, clinicians may see a weakening of either component of the self. The clinician may also see compensatory structures developed to make up for a weak self, such as aloofness, cult-like behavior, addiction, or perversion, to mention a few. Disorders of the self may also be accompanied by narcissistic rage, which is understood as a consequence of a perceived threat to the self, and is triggered and accompanied by experiences of shame, humiliation, and/or disappointment. In psychodynamic psychotherapy, an individual with a disorder of the self experiences a reactivation of the original needs of the self in a variety of transferences. In fact, Kohut first described self-psychology because he felt that the structural model of the mind did not help him understand his patient's transferences. The mobilization of these transferences, or narcissistic or self-object transferences, serve as an opportunity for renewed development of the self. Indeed, in self-psychology, psychodynamic therapy is approached from a developmental point of view. The therapist focuses on the self-object function of the transference, linking the transference to self-object functions that the patient experiences as having been missing during his childhood. In this way, the transference is seen as expressing a longing for these self-object functions to be taken over by the therapist, so that a weakened self can be repaired. In other words, the therapist emphasizes the patient's felt need rather than his or her feelings of having unacceptable wishes. In self-psychology, examination of moments of disruption between patient and therapist are central for therapeutic action. These moments, in which the therapist fails to understand the patient's needs, are inevitable. They provide an opportunity for patient and therapist to better understand what is felt to be missing in the present and in the past, and to better understand what is felt to be required for repair. Meanwhile, there are other important theories of the self in the psychoanalytic model of the mind that we should be aware of. These include Erikson's theories on ego identity and all of his 8 stages of development, Mahler's theories on individuation and her concept of practicing, Kernberg's concept of identity diffusion, which he borrowed from Erikson, in patients with borderline personality organization, Winnicott's concept of the false self and the true self, Daniel Stern's ideas about the development of the self, and Fonagy's concept of the development of the self in terms of the capacity for mentalization, which always develops in interaction with the mother. Fonagy points out that if the mother's affect mirroring is mistuned, insensitive, or otherwise defective, the child may go on to develop what he calls an alien self. There are also many concepts and much research on the self from general psychology and from neuroscience, we don't have time to talk about all of these. Meanwhile, in order to better understand self-psychology, it might help if we compare the basic assertions of this new model with what we have learned from the structural model of the mind or from object relations theory. In contrast to these other models of the mind, self-psychology makes several basic assertions. We will group these assertions using the parameters along which all models of the mind have to be discussed. First, the topographic point of view. We have already seen that the self is largely an unconscious structure. Second, the motivational point of view. The strivings of the self or narcissistic needs are the driving force in the personality, in contrast to unacceptable wishes for bodily pleasure, as in the structural model of the mind, or to needs for attachment and separation, as in object relations theory. Third, the structural point of view. The self is the superordinate structure in the mind, as opposed to ego, id, and superego, as in the structural model of the mind, or to object relations, as in object relations theory. Fourth, the developmental point of view. Empathic responses from caregivers serve an important self-object function, which is crucial to development. Self-object needs persist throughout the life cycle, as narcissistic strivings are never outgrown but develop into mature forms such as creativity, humor, and wisdom. Finally, psychopathology and treatment. Psychopathology is the result of arrested development or self-object failures on the part of caregivers, rather than the result of conflict, as in the structural model of the mind and most kinds of object relations theory. There are many more differences and similarities between our four models of the mind than we have time to talk about. For a good summary, please see Table 9. This ends Episode 9 of the Psychoanalytic Model of the Mind on self-psychology. Please stay tuned for Episode number 10, where we will try to integrate the models of the mind. We feel very strongly that you need not choose among them.